seat, take a big breath. Scenario's over. Okay. We're gonna spend about the next 20 minutes debriefing. We're gonna talk about the scenario. We're gonna have you guys talk over, what worked for you. If things didn't work for you, what the alternatives are, what their pros and cons are, and work through it that way. So first, and then before we end, we'll make sure that you guys really understand what the goals and objectives of this scenario were. You knew Mr. Rogers. And then we'll make sure you've got some takeaways to get going. So first, you guys feeling okay
Yeah.
at this point?
Pretty
I feel
good.
like it went well.
Yeah.
Okay, good. Anything you want to talk about, like right off the top, or?
I just enjoyed the fact that he was very compliant and
Yes.
very friendly, as opposed to being a difficult patient. So that was good to work with, but at the same time, I also noticed that he might be someone that wouldn't tell us if something was wrong.
Oh, interesting perspective, right? Jill, did you get the same sense?
Absolutely, and the way that he talked about himself, saying, I don't like to complain, that kind of thing,
Okay.
that sets off a trigger that I feel like, maybe he's in more pain than he's telling us, maybe he's not telling us about some symptoms that he's having. And so I just want to be super observant of him because of that.
Okay. So what are some of your options then when you're dealing with patients who may not be telling you? What I'm hearing from you is that your sense was that he wasn't telling you the full story, or he may be just being stoic. What are some of your options, really?
I think giving him more open-ended questions instead of yes or no type responses, like, are you feeling pain? Yes or no, versus Jill actually picked up on that, and she went back in and said 0 to 10, gave him a scale, and then went further to ask, where's your tolerable pain level? And so that gives us direction and ability to manage the pain moving forward.
Yeah. Jill, yes, I did observe that you used a pain scale, but then went further into a little bit more detail to really qualify what that meant for him. Because what I heard you say was 6, but what is tolerable? So what were you trying to do with that information?
Well, because he said the worst pain he ever had was in a plane crash, I figured that's pretty bad.
Okay.
So if you're 6 out of your amazingly huge 10, that seems like that's more pain than most people would
Okay.
put up with. So I want to know what he puts up with, so we can manage his pain
Okay.
better.
So with the statement that you followed up and asking him, do you feel like that, what would be a tolerable level for you? Do you feel like you were able to then get a better gauge of where he was at?
Yeah, I definitely felt that if he could do a 3, then he was probably 2/3 of the way to his worst pain. And that probably wasn't, he had high respiration rate, high heart rate, and that was probably some of that due to the pain that he was experiencing. And if he had less pain, those things would probably go down and he'd feel better.
Okay, and then you started talking about pain medications with him. I heard you say NSAIDs, and we're always very clear when we're doing patient-centered and veteran-centered care
Yes.
here, that we use language that they can
Yeah.
understand. But you did follow up with saying and describing those medications and using names he might be familiar with, right? So that's a very veteran-centered, patient-centered approach to it. Did you feel like you would feel comfortable trying to advocate for him taking a narcotic, given how he felt?
That's a good question. I really did want to advocate further as far as trying not to start with the narcotics right away.
Okay.
But he did seem to be amenable to starting with something on a lower dose.
Mm-hmm.
And I would continue, knowing how sensitive he was to it, I would continue to monitor more thoughtfully about how he's feeling pain-wise and how he's feeling as far as
That's right.
feeling high or anything like that.
Okay, great, yeah. So, Rui, any thoughts on, even though you weren't dealing with that, on her approach to the pain medication? Do you have any different thoughts?
As far as pain
Yeah,
goes,
pain medication, managing expectations.
I think just the environment, moving him into a comfortable position, doing anything we can to make him comfortable in the room, so he's not thinking about that or increasing his anxiety, which might contribute to that,
Okay.
because he already has difficulty breathing, so making more anxious might increase that respiratory effort. Other than that, I think Jill covered that pretty well in this scenario.
Okay, great. Well, good, so, yeah, you brought up, right off the top that pain seemed to be, a concern with this patient, and you were reading into it, because certainly, was that anything that was handed off in report to you?
No, it wasn't.
No, it really wasn't, right, but yet you picked up on that from other pieces. So when we're talking about you as new graduates, that critical thinking piece and clinical judgment, my observation is that you are really starting to pull a lot of information and really listen and hear and look for multiple signs. I've heard you say that, so. Let's just go back to the beginning now, and from the time you received a report, I'm interested in hearing you talk about how you guys work together as a team.
Okay, well, I initially started speaking with the patient on one side, so I kind of initiated the communication with the patient, and at that time, Jill took the advantage or the opportunity to go and start the vital signs. So we kind of were multitasking and be efficient with our time to get him the best care as possible as quickly as we could and efficiently. And while I was talking to him, she was taking the vitals. Then we got more information as we were collecting both vital signs and about the patient, so we can formulate a plan of care and to move forward and just be efficient in general.
I appreciated I loved that it was a team effort, because we really could could speak with the patient and listen to him and get vitals all at the same time, and that's really hard to do on your own.
It is.
And I think what ends up getting lost is your ability to hear what the patient is saying, because you're asking questions, but you may not be hearing the answer because you're focusing on what you're doing. And I think patients know that that's happening. They get a sense of that, and they feel like that starts maybe just they start feeling like they're not being listened to, and that can feed into all sorts of things down the line that don't go well. So I think it's really nice that we got to sort of have a conversation with him and also take vitals and get information all at the same time. I like that team effort.
I'd like to add that, we want to make, as far as patient-centered care, we want them to make them feel like we're listening to them. So while I was talking to him, he talked about his daughter and losing someone, a son, I believe, and instead of just asking about his pain, I acknowledged that and said this might be actually a difficult year for you, like I'm sorry to hear that, or you sound like you have a very caring daughter, just to try to establish a relationship with the patient moving forward right away, like as soon as we could. So I think that's very important, something that's often overlooked.
Right. And that's really part of that care model that we talked about when we had the veteran and family-centered care here. So that connecting and rephrasing with the patient and coming up with a plan together. So I appreciate that you did utilize that with the patient in this scenario. You talked about how you kind of worked together. That was a deliberate process. I heard you talking about that. Did it work in reflecting back now? Did it work for you?
I like how it worked.
Yes, it was very smooth.
Yeah.
Okay, yeah. And I also then heard you say that, there's the challenge if you are alone, how do you get everything done and still hear the patient? So if you can think about that now for a minute, what would be your strategies if you're alone and they're talking and you're trying to gather all the information?
I would say to kind of maintain that connection with the patient as you're taking the vitals, and not just focus solely on what you're doing, but maybe maintain eye contact, and maybe have your hand, a free hand, holding their hand, or just establishing some kind of connection. And moving forward after this, I felt that there was kind of some things I was forgetting, or maybe weaker areas of my patient interaction that Jill picked up on, that I would incorporate, as far as moving forward in the pain scale. There's certain things that I wasn't necessarily thinking about at the time, but now I can incorporate moving forward into my care if I was by myself.
Great, yeah. So I think there are some definite things, you are new graduate nurses who have just started. There's a lot of skills and pieces that you must bring together, and that will come with time as well, that you can go in. I do think that sometimes nurses make the mistake of thinking they can completely multitask. So being deliberate, if you need to stop and listen to a patient, that you give yourself permission to do that.
Yeah.
rather than what I heard you say was, the patients are aware when we're not listening to them. So one of the strategies I use is that I will tell the patient, at this time I'm gonna listen, I will talk to you right after
Yeah.
this.
Yeah.
So that we have clear expectations and they don't feel like they have to talk to me at
Right,
that
and I
point,
think
so.
I think it
You
also
were
helps if we even just say, I'm gonna listen to your heart now. And so I guess that gives the impression that I'm gonna be quiet for a minute,
Yeah.
I'm gonna listen to your heart, I'm gonna listen to your lung sounds, and then report on what I heard.
Yeah. And
Because,
Jill, you did that.
yeah,
So you actually did say, I'm gonna listen to your lung sounds right now. And really, I appreciated that when you came around to do some other tasks on the other side, that you weren't trying to talk to the patient at that point. Because we often make
Right.
the mistake of talking, so you're being very in sync with your coworker.
I just doing that like instinctively, but now that you say that, I didn't make the mistake in the scenario, but if I would have spoken, I wouldn't even have thought of that as being like a distraction or keeping the
Right.
patient focused or
Right.
whatnot.
So given some of the time, we're gonna make sure, because we've talked about some key things here, we're definitely probably not gonna go through every point in this scenario. We did mention with the antibiotics, we can review through the proper priming and go through those pieces of it after again with you to make sure that you understand the lines and the tubing, because every hospital you've been at are just a little bit different. And now that you're here at our hospital, we want to make sure that you understand the lines that we're using as well. So you got your report, and we'll just kind of go through it in chronological and make sure there's nothing that you're really missing. You were able to talk to him about pain, you got some family history, got the antibiotics, you got the oxygen, you did your lung assessment. You got a lot of work done in relatively a very short time that you might not have, although the real clinical environment, you will be pushed for time. I'll spend a few minutes talking about your resident from the medical team, and because we're a teaching hospital, came in. You talk to me about what that was like when you were still working and the resident was speaking with the patient. And what
Yeah.
your role as an RN at that time is.
so, at that point, I mean, I know the resident is also pushed for time. So at that point, I would pause and let that interaction happen.
Okay.
If I can get something done while that's happening, I would take advantage of it, but for the most
Okay.
part, I wanna hear what's happening, what the physician is saying, what the patient is saying.
And what did you do in this scenario?
I did pause for a second. The physician talked about the results of the chest x-ray
Mhm.
and the fact that he or she wanted to get a CAT scan, probably today, maybe tomorrow, the timing on that. And then when the physician asked were there any other questions, then I brought up the pain issue.
You did, so you did interface with them. Rui, what do you think about that?
I think it's important to not only allow the resident to speak with the patient, but to keep an open ear to the dialogue and the communication, so that you can add information that the doctor might not have at the moment that you've collected before you came in, for example, with the pain, and then
Sure.
allow the doctor to make the correct decision, and so there's a continuity of care.
Okay. Are there any other benefits to you as a nurse participating in that conversation that would be for the patient? Other than, and I don't want to guess what I'm thinking, but what I've heard from you is that you could fill in information, and Jill, you did that. But once the physician leaves, your role now, because you participated in the conversation, how does that help you and how does it help the patient?
Well, you can ask the patient if they have any questions further that might not have been answered when the doctor leaves.
Great.
And either you have information or you don't, and you can tell the patient, I don't have that information for you, but I can get it for you. So that way the patient
Okay.
will feel comfortable in knowing what is going on with him.
And that's where I really wanted to go with this, is that an important thing, and feedback in the hospital that nurses will give us is that the physician, does not include us in the conversation. But
Yeah.
I would put forth that the nurses often, as you have said, you have things to do and tasks to get done in other patients, often keep yourself busy on the side.
Yeah.
And so as Rui pointed out, when you're part of that conversation, you can clearly hear what was communicated and fill in the gaps for the patient. Think of it, especially if this might have been bad news. And as a patient, they start getting tunnel vision.
Right.
Mhm.
So you're an advocate. So a really important role as new grad nurses is to, even though it's so tempting to want to do the next task
Yeah.
on your long laundry list, is to just pause. It's like when you pause to hear the patient, and even more so, perhaps introduce yourself. Right?
Yeah.
I'm Jill and I'm the primary nurse taking care. I'm gonna listen in here with you and let me know if you need other information. So just take that step up. Does that seem to work for you?
Yeah, just quickly get in there and address
Yeah.
who you are, how you can help, and then kind of get back to what you were doing.
Yeah. Although you're new nurses right now, in about half a year from now, you will be newer than the newest intern.
Mhm.
So you have an important role to help their process of education, so. Yeah, and so then we'll just talk about last before we wrap this up here. And I do have the video, although I'm not sure that there was anything. If you want, we can look at pieces of it after. I'm not sure that there's anything that we haven't discussed, so.
At any point, was there a situation where you felt that we could have asked for a resource nurse? Or what would be a situation that we would ask or call for our nurse?
So I'll reflect that right back to you. Was there any point in the scenario that you would have liked to call for a resource nurse?
I feel that there was a point with the antibiotics that I could have just stopped and paused, like you said, and just realized that this was different and called for the nurse instead of just moving forward and attempting to try it the way I.
So you did move forward,
Mhm.
okay, so you just put out an alternative, right, which would have been to pause. What would be another alternative? Think about real clinical environment.
Maybe ask the other nurse
Okay.
in the room if she was familiar with the pump and she could probably assist me with it.
What
Or
are the
even-
pros and cons to doing it yourself as opposed to asking for help?
Well, one pro would be that I would learn how to do it myself by finding my limitations and then
Okay.
working my way through it. And the con would be creating an error that might be harmful to the patient.
Okay. So in reflection, if you come onto this situation again, how might you handle it?
It really depends on, I guess, what I was working with. In this situation, it was antibiotics, so I felt that it was harmful to the patient in respect to that I might have wasted some of the medication. However, if I was using some saline, which wouldn't really affect, two milliliters wouldn't be too much
Sure.
of a negative effect, I would probably try to work my way through it.
Yeah, okay, so because this is simulation again, and we remember our basic assumption in simulation is that we really believe everybody comes to work to do a good job, so we explore when things don't. So your intention wasn't to waste antibiotics. So here, at this point, I've heard you say that it might be a good thing to call on a resource.
Mhm.
That's always something, and we actually encourage that. We encourage that team participation amongst people. But because this is sim, we will review through that. And perhaps in the next scenario, we have another opportunity to practice this again. So, yeah, so does that go back to your question about asking for a resource?
Yeah, that makes sense. I think it's important to establish understanding when you need help, and the first time that happens is really critical, because if you neglect to ask for help, I feel like you're going to continue down that path, as opposed to if you know you need help and you ask immediately and aren't concerned about it, then you're going to learn a lot more and be safer, I feel, moving forward from that initial decision.
Right. And so when we reflect back to when we had that first orientation session with all of the new grads here together, we talked about one of the biggest things we want you to be knowing is limit setting, knowing your limitations, and not being afraid to ask for help, okay? And then from there is knowing and finding what are the resources in the area you work on, and how does that culture work. So I appreciate that honesty in reflecting back on that. Other than that, there was at no point that I saw, so if I'm giving you feedback, that I felt like we needed to intervene there. To make sure that we understand the goals and objectives of this scenario, what's your sense of the overall goal of this scenario?
I think to be able to assess the patient and treat the patient and be safe and focus on patient-centered care.
Mhm.
Patient-centered care for sure.
Definitely.
And, yeah, make sure we have patient-centered care and also be thorough and
Mhm.
safe.
Yeah, so yes, definitely veteran-centered care was one of our priorities, and we've talked about that. Communication, thorough assessment, because we've done that focusing on the physical, environmental, social aspects of assessment, and not just getting tunnel visioned into perhaps the primary diagnosis of pneumonia. And then also the teamwork and collaboration and how you work together using our crisis resource management principles. So those were the overall objectives. In finishing up here, takeaways, Rui?
I just believe that I want to focus on communication, and as far as my limitation setting, I think is something I can work on just to communicate well with who I'm working with and understand my role and just being effective as possible in that role.
Okay.
For me, just making sure that I have the right information, that I am relaying the correct information, and that I'm also listening and hearing correctly, both from patient, doctors, the SBAR, all of those things. Make sure that I have it, that I've gotten it right, and that I'm gonna also give it correctly.
Okay. Well, great. I thank you for your time today
Thank you.
in simulation. You're going to be back with me in, I believe, 2 weeks. Let me just follow up, because you know that this is case 1 of an unfolding scenario. You are going to meet Mr. Rogers again. So let me just give you a little bit of follow-up before your next scenario with him. So the resident had come in and handed off that they wanted him to go for a CT scan. Mr. Rogers will go for a CT scan tomorrow. He will agree to that, and he will spend 4 days in hospital on IV antibiotics and then return home. So when you meet him next time, you're going to get the next piece of it from where he left in the hospital with the pneumonia and antibiotics.
Okay.
All right. So you guys, I think it's almost time for lunch, so
All right.
again, thank you, and then we'll see you next time.
All right. Thank you.
Thank you so much.